Hello and welcome to today's session. Today we're going to look at triaging in emergency department. So we shall be able to define what triaging is, then proceed by looking at the types of triaging. Of course, that is what is practiced globally and also narrow down to Kenya. We're going also to look at how triaging is done at the hostel and some of the complication of triaging. So welcome to the presentation and let's get right into it. First of all, in defining triaging, the word triage comes from a French verb, trier, which means to sort. So during disasters, the goal of triage is to provide the greatest good for the greatest number of people. And therefore, triaging in emergency department can be defined as evaluations that you as a nurse must perform to gather information quickly so that you are able to assess patients and determine their priority treatment needs and the potential for death. Looking at the historical aspect of triaging, you find that the word triaging was first applied to the process of sorting injured soldiers by Baron Dominic Jean Larrey, and this was during the Napoleon military campaigns. From the picture, you can be able to see our cartoon that for a triage nurse, when they look at you, if you are the worst, then you are the first to be attended to. Okay? Okay. So this triaging process is time sensitive and dynamic. Time sensitive, it means we have to deal within the limited time. Dynamic, the status of the patients keep on changing over time. So you have to act with precision and save time. Also, triaging involves managing high volume of undifferentiated patients, many of whom arrive simultaneously. So you have to cluster them and see who are the ones you have to start with. According to the emergency department protocols, initial treatment intervention may also begin in the triaging area. So if you are a nurse and you receive a patient at the hospital, you need to find out what was the initial treatment or if any initial treatment was provided to this particular patient so that you can be able to track and see how you're going to progress next. Also, providing treatment in combination with triage may also improve patient flow and increase patient safety, which is a good thing. So a facility generally has a specific triaging guidelines for assigning patients equity, and we have several triage equity rating system available. Let's just make it clear that there is no standard triaging system in the world, so they keep on changing. We shall be able to look at triaging systems in developed nations like United States, then also look at UK. Of course, for the triaging system in UK is likely to be practiced across Europe. Then we also have now Canada as another place. Then lastly, narrow down to Kenyan system. So in those developed nations, US, Canada, and UK, they use a triaging system that has four levels. Just differs a little, but actually it has the same concept. So we have the Emergency Nurse Association and the American College of Emergency Physicians. They have sought to establish a standardized emergency department triage scale and acute rating process. So they all support a 5-level triage scale, which is called the ESI, Emergency Severity Index. Although many other 5-level systems exist, just like I've mentioned, one in UK and another one in Canada, and so on and so forth. So the Emergency Nurses Association also recommends in its scope and standards of practice that healthcare providers should consider that the patient's physical, developmental, and psychosocial needs during the triage process. So in 1986, the federal government in the United States passed an Emergency Medical Treatment and Active Labor Act, which requires that all patients who come to the emergency department have to be given treatment, they have to receive treatment, medical screening, just determine where an emergency condition exists. And this law is very important because it seeks to prevent the dumping practice, which is the practice of unethically refusing to treat patients who may not have an insurance or financial resources that can cover their care. So this triaging scale, we have the emergency severity index level 1. This one, the patient requires immediate life-saving intervention. Then we have emergency severity index level 2, level 3, level 4, then level 5. Looking at the one in UK, this is the Manchester triaging system. This one is developed in UK and is used widely in Europe. It also has 5 categories based on the presenting complaints and the flow charts. So the first one, we have the immediate, where we had the time for assessment. To assessment should be 0 minutes, then and is normally coded red. We now have very urgent as level 2. Level 3 is urgent. Level 4 is standard, and level 5 is non-urgent. We can also look at the one in Canada. One in Canada also has 5 levels. So the Canadian Triage and Equity Scale, CTAS Canada, is a 5-level triage system and standard across Canada. So levels are based on equity and recommended maximum waiting times. So like the first level, we have the resuscitation, where it should be done immediately. Then we have emergent, urgent, less urgent, non-urgent. And this one has been adopted in several countries as well. Equally, Kenya, like for Kenya, in reference to the 1986 federal law in United States, Kenya does not have legal. Kenya does have legal provisions. We have the Constitution 2010 and the Health Act of 2017, and this one normally tries to mirror the American concept, where no one should be denied emergency care because of inability to pay. However, the enforcement of this is less structured like the one compared to United States. Constitution of Kenya 2010, Article 43, number 1, Part A, states that every person has a right to the highest attainable standard of health, which includes healthcare services. Article 43, number 2, a person shall not be denied emergency medical treatment, and this is what is closest parallel to the American concept, and it makes emergency care a constitutional right. According to the Health Act of Kenya 2017, number 21 of 2017, section 5, part 2, no person shall be denied emergency medical treatment for any reason, including lack of funds. So this one defines emergency medical treatment to include immediate healthcare intervention, stabilization, safe referral, or transfer. So facilities and providers who refuse to give emergency care may face legal or professional sanction in Kenya. So we also have another triaging scale. This one is more of a global aspect, and it was developed in the United States, specifically California, in the early 1980s, and was created by the Newport Beach Fire Department in collaboration with the Hoag Hospital in Orange County, California. And it is mainly to provide a fast, simple, and reproducible method of triaging large numbers of casualties during disasters like earthquake, mass accidents, and terrorism. So this one is what is abbreviated as START. Simple triaging and rapid treatment, and is very important during casualty or disaster situations. Okay, so the first level, we have the red. So the red one, this is the emergency or the immediate. This one has the highest priority. Patients here need to be treated immediately. Patient will be presenting with life-threatening conditions like airway and breathing problems, uncontrollable or severe bleeding, severe burns, signs of shock, open chest, and abdominal wounds. In this case, the patients need to be treated immediately, including cardiac arrest. The second level is yellow, which is urgent, and this one is delayed. It will be attended to after you are done with the level 1. So it is the second priority. Treatment can be delayed briefly, just between some minutes to hours. So patients with the air with no airway problems, major and multiple bone and joint injuries, back injuries with or without spinal cord injuries. So yellow, they need to be treated soon after you have treated the red coded group. The third group or the third level is the green. This is non-urgent. It's minor, it's the lowest priority. Of course, they have to wait longer, so they'll be treated. They can wait for treatment and they'll be attended to once you are done with the red coded and the yellow coded. Patients here have minor injuries or stable conditions. This could include sprains, could have mild wounds, simple infections, simple infection, minor fractures, and also other minor soft tissue injuries. Lastly, we have level 4, and this is the black coded group, expectant, dead, no priority here. So the patient is dead or they have injuries incompatible with survival given the available resources. We also refer to this group as unsalvageable group or the deceased. So that one is used more in the field, but we also have another scale that is normally used in the hospital basis and is abbreviated as SATS. This one is initial for South African triage scale, and this one was developed in South Africa. It is extensively used in South Africa and is applicable to low and middle income countries, Kenya included. So in Kenya, it is highly practiced in KNH, Kenyatta National Hospital, and this is our main referral hospital for the country. So in this case, we have also color coding where we have 5 colors in this case. The first one is red, which denotes emergency, and this one is a life-threatening medical condition. So patients expect to receive immediate attention to reverse. Number 2, we have the very urgent group, which is coded orange. So here you have a serious medical condition, so you expect attention after the red patients have been stabilized. Then we have the yellow is the third level. You expect attention after the red and orange patients have been stabilized, and that should be within 60 minutes. The fourth one is the green one. So you can function without immediate care and you'll be attended to as soon as possible once we are done with the red, the orange, and the yellow coded group. So this is also kind of routine. You should be attended within 4 hours. Lastly is the blue color where it is denoted, the denoted color blue. So this is the dead group. So emergency department in South Africa use this one and is very important in prioritizing patients in routine hospital emergency, not just disasters like the previous one. So in carrying out triaging process, a triaging session, you need to have vital signs monitoring chart, equipment, also facility approved pain assessment tool, you need gloves, you need emergency equipment, so the code cut with emergency medications like atropine that you have to use in the case of bradycardia. We have adrenaline as in the case as an inotropic agent. We also have salmeterol in the case of asthmatic attack and several other drugs. We also have handheld resuscitation bag and mask or the amp bag to give rescue breaths, and we have the intubation tube, especially in patients who are not able to manage their own airway. Optionally, you could have the gowns, you could have the masks with the face shield or the masks with goggles and the weighing scales. In preparation for the charging process, you have to inspect all the equipments and supplies. so that if a product is expired or is defective or has compromised integrity, you need to remove it from the patient use and you label it as expired or defective and report the expiration or the defect as directed by your own facility. Always make sure that emergency equipment is functioning properly and readily available. In the implementation part of the triaging, you have to perform an across the room assessment just to identify patients who require immediate treatment. So during across the room assessment, you need to observe for specific visual, auditory, and olfactory cues, which include the visual ones. We have the level of consciousness of a patient, signs of distress, respiratory rate and work of breathing, signs of obvious pain and pain's location, skin color of the patient, bleeding, ability to ambulate, and general behavior. For the auditory ones, you look at the ability to speak, audible respirations or secretions, tone of the voice and language, and interaction with others. And lastly, olfactory, you have to look at the body fluid odors, alcohol or chemicals, and the poor hygiene. So once you have performed across the room visual assessments, you go, if the patient is unconscious, you need to shout for nearby help and activate the emergency response system. It could even be via the mobile phone if appropriate in your hospital. Then you check for the absent breathing or only gasping, and if able, you simultaneously check for a pulse to minimize any delay in detecting a cardiac arrest and initiating CPR. If breathing is absent or the patient is only gasping, you don't need a pulse. You don't need to feel a pulse within 10 seconds. You just follow these steps below. You have to have a helper who should help you retrieve a defibrillator and other emergency equipments. And if you're alone, you can retrieve them yourself. Immediately you begin chest compressions until this defibrillator is ready for use. You have to compress an adult chest at a rate of 100 to 120 compressions per minute with a compression depth of at least 2 inches. 1 inch is equivalent to 2.5 centimeters for an average adult, but this should not exceed 6 centimeters. Ensure that you avoid leaning on the chest between compression, and this will allow full chest wall recoil. So after starting the chest compression, you have to open the patient's airway and deliver rescue breaths. So each rescue breath should be delivered over 1 second and use a ratio of 30 compressions to 2 rescue breaths. When the defibrillator is ready to use, you have to check if the patient's rhythm so that you defibrillate if the patient has a shockable rhythm. Otherwise, if not, you continue with the cardiopulmonary resuscitation. Use the components of primary survey, and in primary survey, this is a method of classifying incoming emergency department patients using the patient's primary concern and the results of primary and secondary assessment to set priorities for your patient. So the parameter of primary assessment along with each parameter's assessment steps and intervention are based on those assessments. So starting with the first one, which is the airway A. So we are having the mnemonic A, B, C, D, E. A is the airway, the parameter is the airway, and you're going to assess for airway patterns. The interventions are, you need to open the patient's airway, stabilize the patient's neck, and maintain it in midline position. Then perform the head tilt, chin lift maneuver, or if you suspect that there is a cervical spine injury, then the jaw thrust maneuver will be appropriate. You provide suction as required or as needed. Then you remove any foreign bodies that may obstruct breathing. You use an airway adjunct. It could be an oral or a nasal airway. In more advanced cases, we'll use the endotracheal tube or the esophageal tracheal airway. We can also perform tricothyrotomy or the supraglottic airway as indicated. Notice in our diagram on our left, the head tilt chin lift maneuver and the jaw thrust method of opening the airway. B is the second parameter is breathing, and you need to assess for respiration, the rate, the depth, the effort. You need to assess for the breath sounds, the chest wall movement and chest injury, and the position of the trachea. Ideally, it should be midline. In terms of intervention in breathing, you need to administer 100% oxygen with an appropriate device such as the bag valve mask, and you treat life-threatening condition. So you can be able to see our amp bag, and you're able to see the parts of an amp bag. Notice the expiratory valve, the face mask, the pop-off valve, the PEEP valve, the self-inflating bag. You can be able to see that air inlet one-way valve and oxygen reservoir socket. And then we have the air inlet and the pressure release valves. Then you have the reservoir bag and also the oxygen inlet and the tubing. Whereby we are administering 100% oxygen with the appropriate device here. C is the circulation. What you are assessing is for the pulse, the blood pressure, if there is any bleeding, if you also look at the capillary refill time, the color of the skin and the mucous membranes, and the cardiac rhythm. So remember, you have to perform, you need to palpate the carotid pulse for an adult and also the brachial pulse in infants. And you can be able to see the brachial pulse palpation using our two fingers on our far left. Okay, so in terms of interventions, of course, just to mention also the carotid artery is the preferred site for pulse in adults and children over 1 year, and it's because it's the easiest and the most accurate. But for the infants, we normally do the brachial artery in the upper arm. So in terms of intervention, you need to administer cardiopulmonary resuscitation medications. You also need to defibrillate or perform synchronized cardioversion. Also control hemorrhage by applying direct pressure, establish IV access, administer IV fluids such as isotonic fluids and blood products as ordered, and also treat any life-threatening condition. A, B, C. D is for disability. What you are assessing is neurological assessment, including level of consciousness, pupil reactivity to light, and motor and sensory functions. So you need to do step-by-step immobilization of the cervical spine, which is very important, especially in the airway. So you maintain manual stabilization if you are having some challenges, where an assistant can or should maintain manual inline stabilization of the head and the neck. You as the nurse, you need to apply the cervical collar, where you select and apply a rigid cervical collar to fit in the patient's neck, ensuring it is appropriately padded, and then check for skin breakdown or injuries under the collar. You position on the backboard, so you carefully log roll the patient. You don't lift the patient, log roll the patient onto a long spinal board. Then secure the torso, immobilize the head, add straps and the tape, then recheck pulses and sensation, then use additional padding as towels or foam to improve patient comfort and proper positioning on the backboard. Intervention in the disability, you need to immobilize the patient's cervical spine until X-ray confirm the absence of cervical spine injury. So the last one in primary survey is E for exposure and environment. What you are assessing for the injuries and the environmental exposure could be extreme cold or extreme heat, exposure to skin irritants or other hazardous substances. So in terms of intervention, you need to institute warning therapy for hypothermia or cooling therapy for hyperthermia. Remove contaminated clothing. You need to decontaminate the patient's skin at the E level. Once you're done with the A, B, C, D. So in summary, ABCD assessment, that is the primary survey, you need to perform hand hygiene. If you identify the need for immediate care, you greet the patient and family if present. Identify yourself and offer reassurance, provide privacy if possible, and begin secondary assessment incorporating subjective and objective data. So secondary assessment, we use the mnemonics below as the PQRST and the sample and the old cat mnemonic. So the PQRST, STT, you look at the first P stands for provocative or palliative. So what provokes the symptom that the patient is presenting with? What makes it better? You need to find out. Q is for quality or quantity. What does it feel like? So you use the patient's own words to describe it. R is for region or radiation. Where is it? Where does it radiate? S is for severity. You rate its severity on a scale of 1 to 10, where 1 is the lowest and 10 is the highest possible pain. Timing is for T. How long have you had it? Has it happened before? Lastly, treatment. What treatment worked before the arrival in the emergency department? You need to find out. You can also use the old cat mnemonic, where O is for the onset of the symptom, L is for location of the symptom, D is for the duration of the symptom, C is for the characteristics of symptoms as described by the patient, A is for aggravating factors, R is for relieving factors, and T is for treatment before arrival in the emergency department. Remember, for objective data, you look at the signs and symptoms, allergies, medications, past medical and surgical history, last meal or oral intake, and events leading to an injury. So you have to review the patient's primary concerns and related signs and symptoms. You perform a targeted history, which commonly contains information relevant to the patient's presenting concern and may provide cues to the problem's etiology. You have to review the patient's medications, the prescriptions, and the over-the-counter drugs, which may provide information about pre-existing condition as well as potential adverse effects resulting from the therapy. Perform the hand hygiene as we had indicated. You need to put on the gloves and other personal protective equipment as needed to comply with the standard precautions depending on the patients at hand. In trauma situations, you identify the mechanism of injury to identify the potential concomitant injuries. Also perform a targeted physical assessment, focusing on the patient's primary concern and presenting symptom, and obtain the patient's vital signs, temperature, blood pressure, respiratory rates, pulse, symmetries, all them. They need to have them. Screen for and assess for the patient's pain using the criteria that has been approved by your facility, and this has to take or it has to be aware of the patient's age, the condition, the ability to understand, in fact, in some cases, even gender, and don't delay emergency care just to obtain these findings. You can provide the emergency care, then now obtain the arrests. Assign a shared triage severity rating. It has to base the patient's acuity rating on the acuity system adopted by your facility. Some systems follow an algorithm format. Others assign an acuity based on presumptive major symptom or disease categorization. We have looked at the Canadian triage system and the American Emergency Severity Index. So this one they normally assign from 1 to 5, with 1 being the most severe and 5 being the least severe. Some facilities use computer-based electronic triage system to enhance correct equity assignment. Some equity systems identify a time frame for each level within which a patient should be seen by a practitioner. So you have to communicate the triaging level to the emergency department team. If appropriate, you ascertain additional information as needed. Your facility may require some additional information such as domestic violence screening, weight of that particular patient, recent travel history. Like for the case when you had when we had COVID, we were talking of the Wuhan in China history. It was a risk factor. Nutritional assessment, tobacco and substance use, suicidal ideation, and vaccination also history. You initiate appropriate treatment interventions or protocols. These interventions may be nursing actions, just like positioning or applying ice, or protocol driven practitioner orders, like administering drugs, antipyretics like paracetamol, or inserting an IV access, obtaining an ECG tracing, or obtaining X-ray. X-ray just to rule out cervical injuries. Provide patient teaching, initiate teaching about patients' potential conditions and the care plan. If appropriate, you can offer information on injury prevention, but this is once you have stabilized the patient. So because a patient's conditions can decline while awaiting the emergency department, you need to continue to monitor triage patients who remain in the ED waiting area. Multiple factors may limit the opportunity to have the patient seen in the ED immediately. So you have to remove and discard your gloves and other PPE if one, then perform hand hygiene, then document the triaging assessment, the triage level assessment, the care and the teaching you have provided to the patient. Some of the special considerations that we have, you find that mistakes in the triaging are very likely to occur when an experienced nurse obtains the patient information. And for this reason, Emergency Nursing Association recommends that triage responsibility be limited to registered nurses with at least 12 months emergency department experience and an education in triage principles and other specialties such as pediatrics and cardiac care. When in doubt about the triage category to assign to a patient, it's always safer to assign higher of the two categories. If a patient is a child, you need to be sure with that age-specific, developmentally appropriate family-centered care needs to be provided. A mnemonic that you can use to triage assessment of pediatric patients is the sample, where you ask about the signs and symptoms, any allergies of the child, any medication that the child is using, any past medical problems, the last food or liquid that the child took, or events that led to the injury or the illness. If the patient is an older adult, you ensure competence in care. Many elderly patients take various medication, polypharmacy, and their conditions may be a consequence of drug adverse effects or an interaction between two or more drugs. And that's why we discourage polypharmacy in adult patients. If the patient is pregnant or of a childbearing age, you inquire about the last menstrual period and the possibility of pregnancy. As determined by your facility, you may evaluate a pregnant patient in the emergency department or you take them to the labor and delivery department. You ask a pregnant patient who is over 12 weeks gestation if they are able to feel fetal movements, because we expect fetal movements from that time. Other issues to ask include urinary symptoms, lower back pain, hypertension, vaginal bleeding, edema, seizures. Keep in mind that the patient's cultural background may affect values relating to personal space, eye contact, touch, acceptance of disease or treatment options. You need to be aware of the language differences which might create barriers in obtaining important accurate information. So such resources as language banks may facilitate the process of communicating with a patient who speaks a foreign language. When assisted by an interpreter, ensure that that person is competent in health specific terminology. A patient returning to the ED within 72 hours of initial visit for the same concern is considered high risk. So you consider whether the patient's condition has worsened since the first visit or whether the initial diagnosis and treatment plan were incorrect. Then you provide referral to chaplaincy and palliative care as appropriate. So final complications of triaging, complications associated with the emergency department triaging may be classified as over triage or under triage. For over triage, it might result in patient taking up valuable resources such as bed in an overcrowded emergency department or time for an unavailable healthcare provider. Overcharging might also result in making resources unavailable to another person who will need them more. Undercharging, on the other hand, might result in assignment of a lower equity to a patient than the condition warrants and could also result into delayed care, condition deterioration while waiting to receive patient care. So this is one of the questions that are related to triaging, where we're being asked that a local chemical plant has had an environmental leak requiring the mass evacuation of its employees and neighbors in the surrounding area. The emergency room is in the triage area when the first client is brought to the hospital. What should the nurse do first? Should they cut off the client's clothing and dispose of it in hazardous waste containers? Should they place the patient fully clothed client in a shower for decontamination? Should they determine what decontamination measures took place in the field before approaching the client? Should they discharge or admit all the current clients in the emergency department? Looking at all the options and looking at your safety of you as the healthcare provider first, you need to determine the contamination measures that took place in the field before approaching the client. During a disaster, the nurse priority is personal safety. So determining what decontamination measures have already taken place will inform the nurse of the necessary precaution. The nurse should not cut off the clothing or place the client in the shower until an assessment of hazardous material has been completed. Containing the exposed client in an area free from other clients is important, but the safety of the healthcare provider is a priority. Okay, guys, ladies and gents, that is marks the end of our presentation on triaging. Please check the description section for more quizzes for your own practice. Thank you.